Hello, everyone. I'm Carmen Puliafito, and I'm here today with Dr. Alan Ho, who is professor of ophthalmology at the Wills Eye Hospital and a distinguished retina surgeon. Welcome back to Retina Synthesis, Alan.
Thanks for having me once again, Carmen.
Gave a terrific talk at the angiogenesis meeting about gene therapy for neovascular AMD, in particular, the subretinal RGX 314 trial. Can you tell us in general about what the concept of gene therapy for neovascular AMD is all about?
Sure, absolutely. The concept of gene therapy for wet AMD and these common retinal conditions, it's being looked at also for dry AMD and also for diabetic retinopathy, is that we can use gene therapy to insert a gene to create a therapeutic protein in the eye. Consider, for example, that Lucentis, Eylea, they're therapeutic proteins, anti-VEGF proteins, and we can use that biofactory approach to gene therapy as a way to treat chronic conditions. We're in a gene therapy era now. When most people think about gene therapy, they think about a genetic mutation and taking a normal gene and replacing a defective gene, which was the foundation for the first in-human gene therapy approval, which was Luxturna, Spark's approval for LCA, RPE65 mutation. And the public thinks about it in that context, but we're using, retina is really pioneering this kind of biofactory approach. Gene therapy is also being used in certain hematologic conditions. It's also approved for some neurologic conditions like spinal muscular atrophy. But this biofactory approach is particularly suited for some of these chronic conditions that we know respond to protein therapeutics.
So there are three delivery approaches for gene therapy. Can you go over those?
Sure. The in-office approaches are, of course, intravitreal injection, and that's being looked at by the Adverum group. They're reformulating and restarting the wet AMD trials. They're not continuing for diabetic retinopathy. The other in-office approach, which is being looked at, is a suprachoroidal injection. So that's in the office. And my talk at angiogenesis was on the pars plana vitrectomy to subretinal delivery approach to these gene therapies, potential gene therapies, and that's in the OR and a surgical approach.
So there's long-term follow-up in the RGX trial. Can you tell us how the trial was designed?
Yeah, like any new exploration in our retinal clinical trials, it starts with safety and efficacy, and those are phase 1-2 trials. And we have 42 subjects in the Regenx 314 phase 1-2 clinical trials, and those were dose escalating in 5 cohorts with 42 subjects. And what we learned in this phase 1-2 trial that's ongoing in an extension, long-term follow-up, that's what I spoke about at angiogenesis, is that the biofactory thesis of taking this transgene with a viral vector, putting it under the retina and producing essentially, the transgene encodes for essentially ranibizumab, can work. And we saw dose-dependent protein production that was durable over time. So the biofactory worked. We observed that. We observed that it was well tolerated over time. We did a variety of different things to try and improve the efficacy, so to speak, and the safety. Surgical delivery, of course, always has the variable of the surgeons themselves. So there was surgeon training. So it's been a good journey, fun learnings, working together with instrument companies, surgical design companies, with Regenx Bio, with Gyroscope for dry AMD, with Adverum for wet AMD, and previously for diabetic retinopathy. So it's been good. And we reported on the long-term 3 to 4 year follow-up of some of these subjects, which show really significant reductions, meaningful reductions in treatment burden for these previously treated wet AMD patients. Said another way, you take a patient that was getting essentially monthly therapy, put the intervention in, and some of these patients require either no injections over time or very few injections. So we're addressing this burden of treatment issue, and it'll be interesting to see whether or not they have better vision over time with this kind of steady state production of anti-VEGF than clinical trials or real world data which show improvement of vision over time and then declines over years 2, 3, 4, and 5.
That's great. Tell us a little bit, what % reduction in terms of treatments?
Yes, I spoke to some that were, you're pitching a shutout where someone that got monthly therapy doesn't need any injections anymore, to on average about 60 to 70 to 80% reductions in annualized injection rates. And that's meaningful. That's meaningful over time. Some of the patients in the first 2 cohorts where we found out that the production of the therapeutic ranibizumab was not significant, required monthly injections. So we knew that we were getting into the right range of therapeutic levels when in cohorts 3, 4, and 5 of the 5 cohorts, 1 and 2 were essentially controlled. They required frequent injections just as they did before. These were previously treated wet AMD subjects, but in cohorts 3, 4, and 5, we saw visual acuities that were stable to sometimes improved, OCTs that were stable over time, and injection frequencies that plummeted on an annualized rate.
What about safety?
Safety, we saw, good safety, well tolerated. We did move the position of the subretinal bleb to an inferior position. We had 1 subject in cohort 5 that had pigmentary changes that crept into the macula and had loss of vision. So as I was alluding to the journey and learning and reviewing cases with other surgeons on how to do the injection efficiently, where to put the injection, we now do it inferior to the macula so that pigmentary changes, when and if they occur, are not going to involve the macula.
Tell us about the surgery and the micro injection. How's that work?
Yeah, so people ask me this question all the time. And first of all, I'll say that it's a vitrectomy and then it's a subretinal injection. And I think it's, in terms of generalizability, I think any vitreoretinal surgeon that does vitrectomy surgery could do this. Not everyone does subretinal injections, for example, for submacular hemorrhages. I do. So it was kind of familiar in a way. It's a pars plana vitrectomy. What I've learned from doing the other gene therapy trials, for example, on younger patients with inherited retinal degenerations, you need to make sure that the surface of the retina is clean so that there's a PVD, but then you need to throw down some triamcinolone to make sure there's no cortical gel left over, because that can occlude that 41 gauge subretinal injection cannula. We've used now hardware that was developed by other companies so that it's surgeon foot pedal control of the injection. The Med1 injection system is very good. Instead of having someone that you need an assistant to inject, you can just control it with the foot pedal of the viscous fluid injection system. So there are a variety of refinements in technique, hardware, and really placement of the bleb that make this, I think, very generalizable.
What about intraoperative OCT and bleb creation?
Yeah, that's, I have used that and it's fun to watch that. I don't think you need it, but it is nice. And we did use that on a lot of our younger patients in the gene replacement inherited retinal degeneration trials. Those are much more difficult to elevate, probably because Sometimes there's some vitreous gel that will occlude the subretinal cannula, and or because the photoreceptors are more adherent to the RPE in younger patients. The older patients, the blebs come fairly consistently and fairly easily. Avalanche, which was the generation 1 of subretinal gene therapy for wet AMD that did not work, I think was troubled by a couple things. One was the surgeons weren't getting it there consistently. And number 2, they probably had the wrong viral vector and the wrong transgene. We have a proven transgene with the Adverum program, which is essentially aflibercept, with the Regenix program, which is essentially ranibizumab, and surgeons that have more experience getting to PATER.
So the phase 3 trials are underway, and
Phase 3 trials are underway. It's exciting to think about.
What can we expect?
Yeah, people ask about timelines, and I always try and be conservative. It's not going to happen in the next year, but we'll have to get fully recruited over, 600 to 700 subjects, and then get the follow-up of those patients before their submission. But I'm cautiously optimistic that we'll be having this tool in our toolbox for patients with wet AMD. Maybe in a few years.
That's great. Thanks a lot for your time and for a great summary of something that's very exciting. In this year's physicians survey by the American Society of Retina Specialists, they asked the question, what do you find to be the most promising new development in neovascular AMD treatment? And gene therapy was the leading reply at this point in the survey.
I did not know that. Like I said, safety first, efficacy, and what's good for the patient. Those are the ingredients that we're looking for, and I think we have potential here. We'll see.
Alan, thanks a lot for your time today.
Thank you, Carmen. Nice to see you.